Yo, it's Ronald again, back with another Let's Learn snapshot. And today we're going to talk a little bit more about COVID-19 because apparently that's still a thing that's happening. As I mentioned multiple times in my original COVID video, a couple of the things that were initially said in that first couple of months of the pandemic have become a little bit more outdated, so I figured I'd do an update. Although some of my kind of observations and predictions have held up better than others, and we'll go over some of those. So here we are coming back to all of this. I was really hoping I wouldn't have to make this video, to be honest, but apparently this is all still going on. We're going to go over the effectiveness of currently available vaccines on the new Delta variant. We're going to go over advances in medical management and lessons that we've learned from over a year of dealing with the coronavirus. And unlike that first hour-long video, I'm going to try and be a little less long-winded and keep the video length a little bit more reasonable. Links to sources in the video description. So without further ado, let's get into it. First, let's just go straight into one of the big conversations that a lot of us are having these days. Let's talk about the vaccine. Well, perhaps I should say vaccines. There's quite a few available these days. There's the AstraZeneca, Pfizer, Johnson & Johnson. There's Sinovac from China, although probably you don't want to get that one if you're not in a third world country where that's kind of mainly your main option. Some of you may have wondered, with the emergence of new variants, Alpha, Gamma, Delta, these vaccinations, these vaccinations that were around before these variants, if I got vaccinated with Pfizer shortly after it came out, is that still covering me? Is it still effective to these new variants? We have some studies on the matter at this point, and it seems like for the most part the answer now is yes, for the most part. Now, a July 2021 case control study, admittedly a lower level of evidence with some caveats to be sure, did find that there was a few percentage difference between Alpha and Delta variants as far as the effectiveness of the vaccine, something like 4 to 10% when you had 2 doses. Typically most estimates ranging closer to that 4%, less than 10%. Whereas if you had only 1 dose, that variance went up a good bit. If you only got 1 dose and aren't, as they say, fully vaccinated, that variance is often more than 10%. This really re-emphasizes the need to finish the series and get fully vaccinated. And this, of course, leads us to our next update on COVID and vaccines. So Johnson & Johnson a little while ago had a press conference regarding some preliminary data with regard to a third vaccine, like a booster shot. So they have some ongoing phase 1 and 2A trials that are evaluating the effect of a third vaccination. They have some ongoing phase 1/2A trials on the effectiveness of adding a third shot to the established 2-shot series. It seems that this has a significant effect based on preliminary data, but ultimately the verdict is a little bit out as far as phase 3 clinical trials go. So we're going to have to see for sure as those come out, but it seems promising at the moment. Actually, one of the hospitals that I work at has actually started offering booster shots to healthcare personnel. Now, before we move on from the vaccine, I want to make a quick note of something that was brought up by somebody I'd seen as a patient that I hadn't actually heard of until she mentioned it. Supposedly some people had been saying that there might be some issues with people's menstrual cycles after they had gotten the COVID vaccine. That's sketchy, let's put it that way. So the idea is simply that some people think that maybe the COVID vaccines might have some changes in people's menstrual cycles, and it seems like some people are under the impression that maybe it could potentially sterilize you or something like that. That's a bit of a stretch, honestly. So it is something that people are in the scientific community taking somewhat seriously. So at Johns Hopkins, I believe about a month ago, they started doing a study to inquire about what, if any, effect COVID-19 vaccinations would have on women's fertility and menstrual cycles. This type of rumor thing going around doesn't have a lot of mechanistic basis. It's more of an observational thing, and really there's a lot of things that can change aspects of people's menstrual cycles. Stress can do it. Changes in sleep patterns can do it. I mean, and a lot of that type of stuff has been, just prevalent in people's lives ever since the start of the pandemic. A lot of stuff has changed. And so one would expect that these types of societal environmental factors, if anything, are probably more contributing to any sort of observed changes in people's menstrual cycles, as opposed to actually having gotten the vaccine. Now, what I would also point out is that mechanistically, it would potentially make a bit more sense that COVID-19 itself might have more of an issue on your actual fertility. After all, there are ACE2 receptors in the testicles and ovaries. So if anything, we might also be keeping an eye on long-term the effect of actually COVID-19 on people's fertility. And whether that has any effect on, babies as far as, low birth weight, microcephaly, stuff like that. I don't know that we have actually found a lot of positive evidence for severe birth defects or anything from COVID-19, but looking at women's actual fertility post-COVID infection is something we're actually going to be on the watch for, to see if that is something that we really need to be worried about a lot. In which case, it would make more sense to just get vaccinated. I think worrying about the vaccine with regards to menstruation and fertility is probably barking up the wrong tree compared to worrying about COVID with regards to menstruation and fertility. It would make more mechanistic sense. And if we do find in that Johns Hopkins trial that there is some link between the vaccine and decreased fertility, then we'd have to really look into why that is, because at least on the surface, it's not super obvious why it would be. Okay, let's move on so that the snapshot doesn't become a full Let's Learn, of which I'll likely be doing another one, maybe on high cholesterol, after another snapshot or two. I'll probably dip into crypto again. By the way, please feel free to let me know in the comments what exactly you guys might like to see. Next, we're going to touch on some virus basics and then move on to treatment. So, like I mentioned in my original COVID video, COVID-19 uses the ACE2 receptor to enter cells and cause infections. And ACE2 receptor, unlike the way influenza enters cells with different receptors, ACE2 is present in a lot of different tissues, right? Bile ducts, testicles, ovaries, a lot of different places, with pancreas and a bunch of other places, some parts of the kidney as well. And of course, heart cells, lungs, GI system, and that kind of accounts for a certain degree of the broad manifestations of COVID. You can get myocarditis, you can get potentially some kidney injury, things like diarrhea, nausea, vomiting. These are very common in the course of a lot of illness with coronavirus. And this is, as I explained in the previous video, a result of all the different tissues that have the ACE2 receptor. Another idea that's pretty established at this point is the idea that the severe acute respiratory distress syndrome caused by COVID-19 is in many ways clinically distinct from ARDS that is caused by other causes. The lung tends not to be as stiff, and we mentioned this in the other video as well. It was more of an observation at that point, but it's pretty well established now. You can get that severe disease that looks very similar on imaging and stuff like that to ARDS from other causes. But in terms of how the lungs react to what we call the lung protective strategies that we talked about before, is not quite the same. They don't tolerate very well. As such, we don't have necessarily the COVID-19 equivalent of the ARDSNet trial as far as what exactly helps with mortality benefit. At the moment, we're kind of just playing it by ear a little bit when it comes to the intensive care unit and the lung protective strategies and how we deal with people on the ventilator. If you have full-on ARDS and you actually are, able to synchronize with the vent and actually tolerate those lung protective strategies the way they're trialed in ARDSNet, then we try and do that. But a lot of people don't necessarily tolerate that well. I will say that I often run into ventilator synchrony issues with a lot of these COVID patients, and it's not uncommon these days to have to use a little bit more of paralytics like cisatracurium infusions to completely paralyze somebody down to the vent so that we can actually take over and have them blow off CO2 and oxygenate under our control while they're not bucking the vent, which can be a problem. The role of a cytokine storm in COVID-19 remains a popular idea with a mounting body of evidence behind it, and some against it. There remains a bit of controversy, in particular with regard to the degree to which the cytokine storm actually contributes to the severe lung disease and more severe cases of COVID-19. As at least in terms of the actual measurement of cytokines, the cytokine storm is actually a bit more tame, we're finding, than in some other etiologies of ARDS. We still think generally that this was a disease that came to us zoonotically from bats. However, the intermediate species that it may have come through or mutated in is still not well known at this point. Something we talked about in the original video was the tendency for COVID-19 to induce a hypercoagulable state. In other words, it makes you more likely to form clots like deep vein thromboses or pulmonary emboli. Back in the day, last year, we were at times routinely anticoagulating people with certain inflammatory markers that, if they were high enough, we would just put you on therapeutic anticoagulation, like a blood thinner, basically. Let me explain that. So there's different dosings of blood thinners, basically. You can have a prophylactic dose, which is pretty mild. It's kind of routinely used in the hospital to prevent people who are in the hospital and therefore often not moving around very much. We don't want them to get clots and have them have an extra problem because they were in the hospital. And so we use relatively low doses of those to kind of ward that off a little bit. But there's also therapeutic coagulation, which is, higher dose, which is really thins the blood a lot more. We do not do this type of routine anticoagulation anymore. The most recent guidelines are the most recent guidance from, CHEST, which is a big, CHEST scientific journal in medicine that's pretty prestigious and highly thought of. That had a lot of guidance, and really it does tell us that we shouldn't probably be routinely anticoagulating. There's probably a lot more bleeding events, and without the evidence of actual clot, until you actually demonstrate that there's a DVT or a pulmonary embolism, it is just not really worth it. It makes people bleed more. We also don't routinely send people home on extended chemoprophylaxis. In other words, we were at a time sending people home with either blood thinner shots or a pill that you could take even after you got out of the hospital, because we figured, these people are hypercoagulable. Maybe we should give them maybe a month of something like a Pixaban or something that would thin their blood until they got all the way past the virus. That doesn't seem to have enough utility and too much side effects and risk to that. So we don't do that anymore. We also don't anticoagulate anybody without evidence of clotting demonstrated. We scan people plenty. We scan the crap out of people. But unless some of those scans are positive, we don't necessarily just start a blood thinner. On top of this, we don't necessarily routinely scan for asymptomatic patients. Although, admittedly, there's a lot of variance in what you'll see in, for instance, like the emergency room. Some people they have a very low threshold for doing CAT scans, angiograms of your chest to make sure you don't have a pulmonary embolism if your D-dimer is high enough. It's an inflammatory marker. We have a better understanding of risk factors for worse outcomes with COVID-19. Obesity in particular. Honestly, not even just obesity, but even being a bit overweight, what we've seen, even being overweight as opposed to straight up obese, but especially with obesity, BMI greater than 30, that is definitely a risk factor for doing worse with COVID-19. To the point where I've seen young people with no other risk factor except the fact that they happen to be overweight or even obese, especially if you're in some cases I saw a 22-year-old girl who was quite obese with no other risk factors. She died horribly, and there was no other real reason for that to have happened. And this is something that we noticed pretty early on, and it really doesn't surprise me that at this point we've essentially established that. Male sex, I did not see coming. I didn't realize that was going to be on the list. That did catch me a bit off guard. I didn't know that. But just about everything else on this list that I've brought up on the screen, including, chronic lung disease, underlying conditions like diabetes, hypertension. You could have called that as well. That's something that we kind of figured. People like that do tend to get worse. Conditions like diabetes especially, technically that is an immunocompromising condition. Your type 2 immunity isn't as good with diabetes, especially if it's poorly controlled. We have a bit more insight into how long people remain infectious. We typically only see people shedding infectious virus for about a week or two after the onset of symptoms. And after that, they typically, you can potentially find viral genetic material. However, it's typically just dead stuff. It's not infectious. After about 10 days, especially, so if you have mild disease, we'll typically cut it off at 10 days, and you can come off of quarantine or isolation. You don't need the same precautions. But I will say that there's a bit of variation there, and I have personally seen a person who got a lot of his family sick, and he was sick for weeks. And so usually at that point you shouldn't be contagious. And even with more severe disease, we'll go to like 20, 21 days. And then stop our isolation precautions and go in without, N95s and stuff to the patient's room. But in this one case I'm thinking of, he was sick for more than 10 days. And he got like at least 8 or 9 people in his family sick, because kind of figured that, this wouldn't still be happening. One thing to watch out for there is fever. There's different kind of, in terms of how we think about the progress of the disease, there's kind of the actual viral infection stage, in which case you may have fever, and then there's the post-viral inflammatory phase, wherein a lot of the damage can actually be done around then, kind of by your own immune system. And so the case that I brought up just now is definitely an outlier there. Typically, like I said, in mild disease, after about the 10th day, you stop thinking that people are infectious. Reinfection is a thing. It was kind of something that I kind of figured a long time ago. I mean, we definitely saw people who tested negative, and then a little while later they tested positive again and had a fever. So it was like, all right, so we didn't think it was going to be a thing early on, but I even in those first couple months, I saw a couple people who came in with exactly that story. And so you can't really deny what you saw with your own eyes. And at this point, relatively established. Typically that reinfection tends to be less severe, but I don't know how much I would count on that going forward, especially as the virus mutates and we get, completely different variants that might have more resistance to vaccines that have already been released. I wouldn't be surprised if in the future we end up having to reformulate vaccines on a regular basis for COVID, just like we do for the flu. And of course we have to mention so-called long COVID, or post-acute sequelae of COVID-19 infection, which at this point is a pretty formally recognized entity. Of course, that formalization is a bit rough, as the precise definition of that is, it remains pretty nebulous. I've seen estimates saying something like, 10% of COVID-19 survivors might be affected by long COVID. But once again, that kind of depends on which definition you use, and so this is a bit of a development in motion at the moment. Now come the treatments. Might as well start with the established stuff. Steroids, and then the becoming less established stuff, remdesivir. Remdesivir is a broad-spectrum antiviral that we touched on in the previous video. It is still in regular use in a lot of facilities, especially in kind of moderate to severe COVID patients that are on oxygen. One trial even demonstrated that the combination of dexamethasone and remdesivir may be better in terms of kind of recovering from the illness a bit faster than, say, dexamethasone alone. Now here's the thing. At this point, the NIH and the WHO both recommend against routine use of remdesivir. Now, the WHO actually recommended against its use a while ago, more for pragmatic reasons than anything, but at this point we have something called the Solidarity Trial, which looked at a couple of different drugs, including remdesivir, hydroxychloroquine, and another antiviral that's typically used for other disease. And after that, which demonstrated that remdesivir doesn't seem to have much benefit and it's really not worth using, The NIH now has more recently come out saying maybe we shouldn't be using remdesivir routinely and joined the WHO, but more for evidence-based reasons. Now, occasionally we may still use remdesivir, and actually some people use it routinely still. I've kind of fallen off that bandwagon. I don't really routinely use remdesivir. A colleague of mine brought up a good point recently that in the actual viral phase, you know, that first phase where you might have fever and stuff like that, maybe there's active viral replication, it may be worth using remdesivir. And so that's something I've kind of taken into account ever since he said that. I hadn't thought about it that way. But in other cases, especially if you come past, you know, day 7, 10, you're not really having fever, you might be past that initial acute viral phase, I just don't see that it's even worth using. Dexamethasone does still see routine use. If you're on oxygen, you come to the hospital, we're giving you dexamethasone. Whether you end up getting hospitalized and staying, or if we send you home with oxygen, we'll give you dexamethasone. Once again, it does remain the primary drug that we have that has been shown to have some mortality benefit. So that's super important. When I say mortality benefit, I mean literally, if you're going to die from COVID, it makes you less likely to die from COVID, which is pretty important. Now, why don't we throw a new antiviral in there? And for good measure, why don't we make its name super difficult to pronounce? Favipiravir. It's like a tongue twister. I don't know why they named it that, but favipiravir. A meta-analysis of 9 studies showed that it had improvement in viral clearance rate, requirement for oxygen, ICU admissions, and mortality. Sounds great. So do we use it? No. It's not available in the United States. Otherwise, we would definitely think about using it, but no, I can't use it, so what are you gonna do? We're not gonna spend as much time on opaganib as, you know, it's still in kind of like phase 2 trials and we don't have a lot going for it right now, but maybe I'll revisit that in the future. Maybe if I have to do another video. We'll see. Tocilizumab, a monoclonal antibody against IL-6, which I believe I mentioned just in passing in the previous video, has kind of gained a bit more traction, and especially in some facilities we had started using that a good bit more. Primarily the evidence for tocilizumab in its trials has to do with reducing the need for getting on the ventilator. One thing is that a lot of people with COVID that go on the ventilator have difficulty getting off the ventilator, and so we see that as an important thing. So tocilizumab was used in a number of patients. If your, you know, kidneys and liver kind of allow for it, if you don't have too much damage or anything there, we consider things like tocilizumab. Now, I will say that at this point we do have some negative trials with tocilizumab as well, and so there's a bit of ongoing controversy as to its utility. There was some retrospective data from my residency program while I was there, suggesting that tocilizumab may have some mortality benefit as well, but once again, this is retrospective data, not as strong as more like prospective, double-blinded, randomized controlled trials. So that would be something, if it did come to anything in the future, we'd have to study it further. As I mentioned in my last video, you know, hydroxychloroquine, chloroquine, we don't really use these at all anymore. There's really not much evidence for that. Especially on the heels of the Solidarity trial, which once again told us that likely this doesn't do very much of anything. We don't really use them. Certainly not in combination with azithromycin. Another development I didn't really see coming, I didn't really mention in the last video, was the combination use of baricitinib and remdesivir. So baricitinib is another small molecule drug that is shown in the studies. It was studied with remdesivir. And the idea is that it reduces time to recovery by about 1 day. The effect size is about 1 day. It's not, you know, usually the game-breaking difference maker, but I have seen a couple patients who got it, and perhaps this is just coincidence, they got better pretty quickly shortly after. But I've also seen a number of patients that got it and it doesn't seem to do very much. It's really something you gotta think of in terms of number needed to treat. Not everyone is gonna see this immediate effect, and ultimately the thing that it's studied for is reduced time to recovery, basically. And so it's not something you'd see like kick in at a certain point. The whole course of your recovery would become slightly less protracted, usually by about a day. Baricitinib is a drug that we already had. It's actually a JAK2 inhibitor that's more commonly used to treat rheumatoid arthritis. It's an immunomodulator. The evidence here is from the ACTT2 trial, and that was with remdesivir. And once again, it had no effect on mortality, and so it's kind of more of a way of just kind of speeding things up a bit. For people who are not in the hospital, or at more like milder cases of COVID, who are kind of potentially at risk of complications if they were to get hospitalized and get more severe, we actually may have a newer outpatient oral option, molnupiravir, another antiviral, developed by Merck and Ridgeback Pharmaceutical. This small molecule drug acts on the RNA-dependent RNA polymerase of COVID-19. Basically what it does is it causes a bunch of errors in the RNA transcripts that COVID-19 produces to try and make more copies of itself. It just causes it to mutate until it's no longer producing functional or virulent copies of itself. The drug is currently in phase 3 clinical trials, and Merck and Ridgeback are currently seeking emergency use authorization, just like a lot of other drugs got in the meantime while they finish up that phase 3 trial, just because there is some very promising preliminary data about its ability to reduce the need for hospitalization. That's potentially a big thing. If we really do confirm that, the effect size is something like 50% reduction in the need for hospitalization, basically saying that if we get to this early enough, during that phase where the virus is still replicating, we could potentially cut this off a little bit if we just give this drug early enough. Interestingly, some studies also suggest that maybe this might work better in combination with favipiravir. So combination antiviral therapy might work better for early on reducing the need for hospitalization. We'll have to see about that. That is actually, there's very limited evidence about that combination, and so I can't use the favipiravir anyway, but ultimately, we don't know that necessarily that oh shit, my COVID, just kidding. We don't know that is going to be a big factor, that combo going forward. That's still being studied. Early days. Then, of course, there's the monoclonal antibodies. There's a selection of these. We'll go with one for now. Sotrovimab. It's an antibody that directly targets the COVID-19 spike protein. The reason I draw attention to this one is because it's specifically been shown to reduce the risk of hospitalization or mortality by about 85%. An odd composite endpoint, but whatever. It seems promising, but personally I'd like to see a good bit more study before we even think about using that routinely. And also we'd have to think about the timeline of when we would use that. These antibodies often work earlier. A lot of these type of things like convalescent plasma antibodies, they tend to be more useful earlier on in the disease course, which makes sense given the paradigm that I was talking about earlier. The virus is there and replicating and viable for a certain amount of time. You may still be sick well after that time, but the virus isn't necessarily there after the first 10 days in mild disease or 21 days in more severe disease. So I would imagine that sotrovimab is more useful early on. We need more data to tell for sure, but it's an interesting development. And finally, convalescent plasma. All the rage around the time of my first video has started to kind of fall out of favor. I personally haven't used it in quite some time. The FDA actually revised its emergency use authorization for convalescent plasma to say that it's only for very early use in hospitalized patients only. And unfortunately, that's largely it when it comes to developments and treatment. We really don't have the COVID version of like antibiotics that just straight kill it and limit the disease the way we can with like a bacterial pneumonia or something. The mainstay of day-to-day inpatient therapy of COVID-19 remains oxygen, so supportive therapy with oxygen. And like I had explained in the previous video, there's kind of that ladder of oxygenation. And for those of you who don't remember or didn't watch the previous video, there's different ways of delivering oxygen if you're kind of low on that. And that kind of steps up based on how many liters per minute we need to deliver to get you saturating at least 92% or more. And so that starts with like a bit of just a simple nasal cannula. And that can rise towards things like high flow nasal cannula, simple mask, non-rebreather mask. Some facilities have like what's called an oxy mask that replaces a lot of this and can more or less be used all the way from 1 liter to 15 liters. And so there's variations of that latter based on the equipment at any given facility. But the short story is basically that you can deliver oxygen all the way up to a certain level before you need to do something like heated high flow nasal cannula. That goes all the way up to 60 liters. And then we use BiPAP afterwards that blows a bunch of air forcefully into your nose and mouth. At which point we stop talking in terms of liters and more in terms of FiO2 and pressure. It's a different thing. But just know that that's above that 60 liter Airvo or heated high flow nasal cannula, and just above that is the ventilator. And so people are always climbing this ladder of oxygenation day to day. Sometimes they get worse, sometimes they get better. And once they get to a certain level, low enough on the ladder, depending on their physician's comfort level, usually I'll let people go home at around 3 liters. We give them some oxygen to go and tell them if it gets worse, you can come right back in. Or if it really gets past the BiPAP stage, then you go on the ventilator. So there's those two ends of the ladder. You either go on the ventilator or you go home. You don't have to be all the way off oxygen to get out of the hospital. And then as far as when do you get all the way off oxygen, that's a highly variable thing from person to person. Some people will be able to get off oxygen after just a few days of being on it. Some people will remain on oxygen for months. I actually saw a patient who was on, I think we ended up having to send her home on like 14 liters or something, because she was there for months and months and months, and she would slowly progress, but it just took so long, it didn't make sense to keep her in the hospital. And so we jerry-rigged a special way of delivering higher oxygen amounts, because usually you would never send somebody home with 14 liters. That's crazy. But in her case, we made an exception, and she ended up being fine, shockingly. That whole story was bonkers. I can't actually tell it to you because it would be a privacy violation, but the whole story was nuts. But suffice it to say, occasionally we send people home on higher amounts of oxygen. But typically it's something more along around 3 liters or so. Before we leave off, I want to throw out a quick word on ivermectin. A Cochrane review from July of this year, 2021, looked at the available literature on ivermectin specifically used in the context of COVID-19. They were looking at, both treatment and prevention. So far, we really only have studies comparing it to placebo, no treatment, or standard of care, which varies from facility to facility and doctor to doctor to some extent. But we don't have studies necessarily comparing it to other proven efficacious therapies. For the most part, the studies that were looked at in the Cochrane review were looking at treatment. There's only one that really looked at prevention. The takeaway from this review of about 14 studies regarding ivermectin and COVID-19 is that we essentially have no idea that it actually is beneficial, and we don't know if it's harmful. It could be harmful. We certainly don't know that it's beneficial. Most of the evidence is very low quality, and most of the evidence finds that it has no effect. But we really kind of don't know. The doses varied between studies, and the duration of therapy varied. None of this seems to be standardized. Even if you were to use it for COVID-19, nobody really has any guidance on how much to take, how long to take it for, what time period it's most effective in, whether it needs to be given super early, whether it might work a little later on, or if it doesn't have any benefit and is actually, harmful. Totally a possibility. I can tell you from my own experience that I've seen multiple people come in after having tried ivermectin. A lot of them have side effects. I can definitely demonstrate, that there were side effects. But I couldn't really tell you that there were a lot of cases where we could even begin to say that maybe it helped. Now, I don't doubt that some people will, take to the comments and talk about anecdotes about, I took ivermectin and I didn't get better until then. We hear that stuff all the time. You got to really account for the fact that your own immune system does a lot of the heavy lifting. You end up getting better anyway, a lot of the time. In most cases, you're gonna get better anyway. Was it the ivermectin that helped at all? Did the ivermectin maybe even slow down recovery? Did it just give you some problems with your GI tract and then it cost you some money and not really help you in the end? Totally possible. Totally possible. And ultimately, since we don't know how much harm it might have, we don't know the dosing, we don't know duration, for ivermectin, we're pretty darn far away from being able to routinely use this in clinical practice. Now, I will say that there are about 31 studies ongoing, clinical trials, as far as, looking into ivermectin further. Like I said, so far we really only have very low quality evidence. But they are, checking into this to see what benefit it might have. I'm kind of pessimistic about this myself, honestly. Ivermectin mechanistically doesn't necessarily make a lot of difference. It's an antiparasitic medication. It could have different mechanisms that it might work with COVID-19, but I'm not hopeful at all for ivermectin. But we'll see. 30 studies. We'll see. For the moment, going in blind with an unproven drug with, unknown dosing and unknown duration, this is not good medicine. And this is not the way we approach it. So until we have some more evidence, I just think it's a bad idea to routinely use this. Just like back in the day, I think, we kind of jumped the gun and started using hydroxychloroquine and azithromycin, and we saw clear harm after that. We really shouldn't be going about and jumping the gun again, because I can tell you, I really do think there are some people that died mainly because we did that hydroxychloroquine azithromycin combo. Thankfully, we're not doing that anymore. I think we should definitely, save judgment on ivermectin and for the moment not use it. And I certainly don't think that, groups of people should band together and start buying it bulk, expecting that it'll give them anything other than diarrhea. So there it is, a brief update on COVID-19. Like if you liked the video. If I annoyed you, hit dislike. Sub if you'd like more like this. We do medicine type content. We do cryptocurrency, personal finance, health and fitness. I haven't done too much of the fitness, but I think I am going to go more towards, diet and fitness videos in the near future. So like and sub if you'd like to see more like that. Good talking to you. See you in the next one.